Welcome, everyone. Woo. So I know some people will be continuing to come in, but we wanted to get started in honor of your very precious time. So welcome to the Department of Epidemiology seminar series. It's great to see such a full house. I'm delighted to present our speaker and my close friend and colleague, Dr. Richard Hoffman. Dr. Hoffman spent the majority of his career in leadership positions, such as the state epidemiologist and chief medical officer at the Colorado Department of Public Health and Environment. And he was also working for the Centers for Disease Control and Prevention. Dr. Hoffman was an early advocate of the Colorado School of Public Health. In fact, he is a passionate supporter of public health in general, and with a particular interest in investing in future public health leaders. To this end, he established the Hoffman Endowment Fund for Public Health Scholarships, which supports students showing high potential in public health programs, such as epidemiology, communicable disease control, and health disparities. With this, Dr. Hoffman is ensuring that our school attracts highly qualified applicants, that students have the resources that they need to make the most of their education, and that they graduate ready to join the workforce as highly capable leaders. In 2003, Dr. Hoffman was awarded the University of Colorado's Florence Sabin Award in recognition of his exceptional contributions to the Health Sciences Center and to the health of Coloradans in general. He lectures here and around the country on a number of public health issues, which is why I am delighted to have him speak today on public health law, disease control, and emergency preparedness. Join me in welcoming Dr. Richard Hoffman.
Well, thanks to Dr. Norris for this invitation, and I have to move fast through this presentation, but I hope you'll find it interesting and informative. So why should you be concerned with public health law? Why should epidemiologists be concerned with that? Well, the authority to conduct disease surveillance and control comes from public health laws and regulations. And you may not be aware of a slight breeze when it's at your back, but you sure notice it when the breeze, when you're facing into it. And similarly, as a practicing epidemiologist, you may not be aware of the public health laws until an unusual situation arises and you find your ability to do surveillance and controls limited. And at that moment, you're headed into the breeze. So what I'm trying to do today is to introduce you to the legal environment in which we practice public health disease control. Lawyers and legislators typically don't know much about epidemiology and public health practice. And likewise, epidemiologists typically don't know much about laws and the legislative process. But epidemiologists need to make sure the public health laws work well for the problems we or they have to solve and manage. So I'm not a lawyer, so why am I talking about this? Well, I've drafted regulations, appeared before the State Board of Health over 95 times. I've drafted amendments to state laws. I've issued numerous public health orders in my career. And the subject of my MPH capstone project in 1982 was the use of epidemiologic data in courts of law. So I've had a long time interest. 3 parts to this lecture. First part, a little dull, basics of public health law, then learning from past outbreaks, and then creating new public health law to address bioterrorism, pandemic, influenza, and outbreaks caused by novel infectious agents. So here's what we do. There's the reported case in the middle, and we're always sort of asking where they got it from and who they gave it to. So we go back and try to determine the exposure, find all the other cases, see if we can interrupt, and then we ask that case if we can, or see if we can determine their contacts and are they well, and try to prevent them from becoming ill. And the faster the case is reported by the clinical setting, whether it be the doctor, hospital, clinic, laboratory, to the health department, the sooner the public health response can begin. So here's sort of what we do. Conduct surveillance, assist physicians with diagnosis and treatment, interview cases to determine when, where, how they were exposed, investigate the circumstances and processes to understand how exposure occurred, identify exposed persons and trace their contacts, organize data, calculate attack rates, determine risk factors, recommend or supply prophylactic antibiotics, antivirals, or vaccine. We might isolate ill persons who are contagious or quarantine exposed persons who are currently well, and we try to stop ongoing exposure. That might be taking food off the shelves in a grocery store or something like that. So what is the public health legal approach? It's a balance of individual rights versus the public good. You all have probably heard that many times. But I think another way of looking at it is a balance of the rights of the uninfected persons and the rights of the infected persons. So the health department is charged with both preventing uninfected persons from becoming infected, as well as assuring that infected persons are treated as rapidly as possible and rendered non-contagious. Always, we are fighting the disease and not the person. And the constitutional basis for this public health protection by states is derived from the 10th Amendment of the Constitution, which says the powers not delegated to the United States by the Constitution, nor prohibited by it to the states, are reserved to the states respectively, or to the people. This is also often referred to as states' rights. And the protection of health is not listed as a specific power or authority of the federal government in the U.S. Constitution. And therefore, state governments, through their police powers, have the primary domestic responsibility for public health. Well, there's a word in there, or two words, police powers. What is that? Well, one definition of police power is government's inherent authority to impose restrictions on private rights for the sake of public welfare. So it's not policemen in uniform. It's not the Denver Police Department or the Aurora Police Department. This is what is meant in this context by police power. And where did this come from? Well, this is a signal case, Jacobson versus Massachusetts from 1905, so 112 years ago. Mr. Jacobson, Reverend Jacobson, he refused to be vaccinated against smallpox. There was an outbreak in Cambridge, Massachusetts in 1902, and the local health department said everybody has to be vaccinated. And he refused on the grounds that the vaccine was contaminated, it was harmful, against his religious beliefs. And he went first to the Massachusetts Supreme Court and then to the U.S. Supreme Court. And the U.S. Supreme Court upheld the requirement of the Cambridge Board of Health to require vaccination. And what is the significance of this? This was the first time in U.S. history that the court had found that certain circumstances involving a public health action, in those circumstances, individual liberty could be subject to the needs of the community. So the police power of the state included public health actions. It wasn't just public safety, which is how you would typically think of police power. Anyway, the court also found that the state may adopt reasonable regulations to protect the public health, and the courts must defer to the legislature's basis for public health measures if supported by scientific evidence. And a public health measure cannot be arbitrary nor impose an unreasonable risk of harm to an individual. There must be some scientific justification and appropriate implementation. And they specifically said in their opinion that though there were some risks from smallpox vaccine, they found that it was a reasonable risk, and therefore they did not agree with Reverend Jacobson. This particular case, on its 100th anniversary, there was an article published in the New England Journal, and Sarah Underwood has a PDF file that you can go to her and that you can read. It's pretty short, a couple, 2 or 3 pages at most, about that case if you wish. Let me just review a little terminology. Legislature is the same as General Assembly at the state level or Congress at the federal level. A statute is the same as a law. Ordinances are the laws of municipalities or cities or towns. Bills are potential laws and are introduced by members of the state legislature or Congress, but they have not yet been approved. And a rule is the same as a regulation. So the process is, after bills are introduced, the staff, legislative staff estimates how much it will cost, and we know that's going on right now in Congress with the American Health Care Plan or whatever in the Congressional Budget Office is saying, 24 million people lose their insurance or whatever. So it's that sort of process. Bills become laws once they pass both houses of the state legislature and are signed into law by the governor, or in Congress it's signed by the president. And there's a lot of talk about public policy. I just want to say laws are one expression of public policy. They may tell people or institutions what to do, or they may remove legal barriers, and I'll come back to that later. Laws sometimes authorize the state health department to adopt regulations. There can be no regulation or public health action without a law granting the executive branch, of which the health department is a part, the authority to make a regulation. And regulations are proposed and adopted by the executive branch, not by the legislative branch. They provide specifics about how the health department is going to implement the law. And once adopted, they are law, meaning you cannot disobey that without risking a penalty. So the actual process is the health department regulations are adopted by the State Board of Health, which is a group of persons appointed by the governor, and there's a legal process, and that process includes a notice informing the public of the proposed rule, the date and location, a statement of the health department's intent and its analysis of the cost and impact, and a public hearing in which members of the public can voice their opinions and concerns prior to the board voting on whether to approve, modify, or disapprove of the proposed rule. All states have laws that address epidemics and outbreaks without reference to specific diseases. Those are called broad authority. And there's also laws for very specific diseases, and I'll mention those in a minute. In many cases, these laws were enacted 25, 70, 75 years ago, and they are intermittently updated. So this is some examples of public health laws that were adopted in 1948, and they're called the Sabin laws, after Florence Sabin. And it says the department has the powers and the duties to investigate and control the causes of epidemic and communicable diseases affecting the public health. Can't be much broader than that. And the department can establish, maintain, enforce isolation and quarantine, and exercise such physical control over property and the people within the state as the department may find necessary for the protection of the public health. So extremely broad power. That was challenged in 1991 and by the legislature, by the Legal Services Committee, because we had been using that authority to investigate and control the causes of epidemic and communicable diseases to basically do surveillance. We said, how are you going to control them unless you do surveillance? And they said, well, you can infer all you want, but it's not there in black and white, and so you're out of business. Fortunately, Senator Dottie Wham came to our rescue and sponsored a bill and updated the law and said the board shall determine by rule and regulation those epidemic and communicable diseases that are dangerous to the Board of Health. So all of a sudden the board is mentioned. The board's authorized to require reports without patient consent, that underlining is mine, of occurrences of those diseases and conditions by any person having knowledge of such. And at the bottom there, any required reports shall contain the name, address, sex, diagnosis as determined by the Board of Health. Then I had another instance where we wanted the telephone number, and that got challenged by the legislature. Had to go in there and say, well, address in Webster's dictionary says whatever it takes to locate the person, and we need the telephone number. And fortunately, a guy named Ed Perlmutter came to my rescue and voted for it, and I've been supporting Ed Perlmutter ever since. I was very happy because I was sweating a lot. Here's some specific public health laws in Colorado. We have one for TB, for AIDS, HIV, sexually transmitted infections, child care, school and college entry, immunization requirements, establishing an infant immunization registry, and rabies and animal control, and I'm sure there's some other ones there. So in most states, the State Board of Health Regulations say what conditions must be reported, when information must be recorded, when reports must occur, who is required to report, and how reports should be made. And the basic compact of citizens with their government is, regarding mandatory reporting, is in return for mandatory reporting without consent of the individual, the government must provide strong confidentiality. That's the main thing. And so the names of persons reported to the health department must not be shared with other government agencies. So if a report comes to the health department, that doesn't mean we can hand it over to a law enforcement agency or the Department of Motor Vehicles or someone else. Remember, no one wants to be reported. If reporting only occurred with the ill person's consent, then many contagious persons would go unrecognized, and the protection of the uninfected could be easily compromised. So here's an article from the New York Times, January of 2016. Outbreak is fueled by mistrust in Alabama. There was a TB outbreak here in Marion, Alabama. And I thought this article was interesting because of the variety of emotions or opinions that are expressed here. So one ill person said, I feel like I'd been around someone that had it. I might die from it if I don't find out whether I got it or not and get it treated. And I was nervous. I was real nervous. Many people said they believed that the authorities had not moved aggressively enough to contain the disease. It's a good thing that they are here to try to help us so this thing won't kill us all. And then the authorities said the outbreak had spread so widely because patients had been reluctant to disclose their contacts. The phrase that every single case uses is, I don't want nobody knowing my business. So you can see both sides are being played out in this particular article. And over here in the right column, where's my cursor? There is a mistrust of government medicine in the African American community, especially because of Tuskegee. And it was the natural history syphilis experiments in Tuskegee that in the, 50s, 60s, and early 70s that led to all of the protection of human subjects regulations at the federal level that is now called, and on this campus, COMERB. Let me turn to physician reporting. There are a variety of reasons why physicians don't report. They not knowing when or how to report. They assume somebody else is going to report. They don't want to report, or they think it's a breach of doctor-patient confidentiality. But it's not. It's not a breach. HIPAA allows reporting if it's required by the states, and state laws, including those in Colorado, usually explicitly state that the physician is not liable for reporting. What improves reporting? Well, if the health department offers some kind of special diagnostic test, we hear about the case, or at least a suspect case, such as rapid Zika virus testing, or if we provide a unique treatment like botulism antitoxin, or if we provide treatments at no charge, such as TB, or if a reporter wants to shift liability from the private sector to government, as in, and this is a direct quote, and I've had this twice in my career, we're closing this hospital unit until you say it is safe. And one of those occurred with the University of Colorado Hospital cardiac cath lab a number of years ago when there was a problem with endotoxins and sterilization of equipment. What usually does not improve reporting? Well, penalizing physicians doesn't help because you might win a little battle, but you're going to lose the war. Public health practice keeps changing. There's new diseases, and there are changes in technology, environment, movement of populations, diagnostic methods, medical treatments, disease prevention methods, ways of collecting data, cultural sensitivity to loss of privacy, and cultural stigma attached to various communicable diseases. And as a result, all those various trends mean that we have to keep updating the regulations on some sort of regular basis. And that's what I was trying to do. I see Dr. Miller here, Lisa Miller. She had to do that, I know, on numerous occasions, and her successors are going to continue to have to do that. It's easier, though, to update regulations than it is to update statutes, because statutes, modifications to statutes, it's time-consuming. It can be risky because you're not always certain of the outcome. Well, let me mention public health orders. We issue them relatively often for isolating somebody with contagious TB, or we have to close a restaurant until changes in food preparation are made, or until we know what the problem is at the restaurant, whether it's the source food or it's the handling of the food, or excluding an unvaccinated student from school during a measles outbreak. A public health order is an administrative order. It's not a court order. Therefore, enforcement is left to the staff of the health department, which usually sort of bluffs. And you get something official. It feels like, uh-oh, and hopefully that keeps you in line, and then they check up on you. But nevertheless, that's not the same as court enforcement. There's also due process. The person subject to a public health order may appeal their actions by the health department to a court of law and get a hearing there. And if you want to have the police or the sheriff enforce the order, you got to get the judge to issue a court order. And after it's issued, all of a sudden, it's no longer the disease or whoever exposed that person that makes them angry. It's now the health department. So here's a example of a public health order issued by, you can see, Texas Department of State Health Services. This was in, let me see if I can get the cursor there, 2014. It was in response to Ebola in Dallas. So it was also signed by the Dallas County Local Health Authority. And it says, under the authority of whatever, you are hereby ordered to implement the following measures. Remain at your residence. You're not permitted to leave. You are not allowed to otherwise permit any visitors. You must monitor yourself, and if you have a fever, you got to call the Dallas County Health Department. You have to make yourself available to representatives, and if you do not comply with this, you may be subject to criminal prosecution, and the order is going to remain in effect until an incubation period is passed, etc. And so what's missing here is due process, because they're not telling the person, oh, by the way, you can go to court if you don't like this. So do public health officials need malpractice insurance? Well, the answer to the question is no. So public health officials in states and local jurisdictions make decisions frequently about how to control the spread of disease. Their actions are legally protected by what is termed sovereign immunity. You're going to have to sue the state, which is not an easy thing to do. It means that state and local officials are immune from civil and criminal liability for their actions, even if they make mistakes or change their minds, so long as there is no willful misconduct. But here we are in September of 2016, and Corrine Miller, the former state epidemiologist of Michigan, had to enter into a plea bargain. The plea agreement states Mrs. Miller was aware of Legionnaire's cases in 2014 in Flint. Here it is up here. Around the time the city changed its water source, and she did not report it to the general public. And she pleaded no contest to a misdemeanor willful neglect or duty in exchange for prosecutors dropping felony misconduct. So there's one example. I don't have any others, so hopefully this happens very, very infrequently. What is CDC's role? CDC is the federal health department. The CDC cannot require reporting of diseases from state or local health departments because of the U.S. Constitution. So state health departments voluntarily send their disease reports to CDC on a regular basis. The reports sent by states don't include the names, although occasionally they will have names, meaning sometimes the CDC will help on an investigation. How can they do that without access to the patient's chart or name or something like that. Anyway, they analyze the data and they often publish findings in the MMWR. In terms of disease control, they issue recommendations to guide public health practice. They will provide expertise to state and local health departments, whether it be epi or lab expertise, usually upon the invitation of the state. They relay information to state and local health departments. Many times somebody will call up from a hospital with a suspect botulism case. They call CDC. CDC says, turns around and calls the state. So we're trying to work together is the idea. It's a system of public health protection, not a bunch of entities that are guarding their turf. And for outbreaks within a single state, CDC will participate in epidemic investigations. They may coordinate or lead multi-state investigations. And at certain ports of entry, they are responsible, such as the quarantine station in San Diego. But they're not really a regulatory agency except for those ports of entry. The other public health agencies, Food and Drug Administration, U.S. Department of Agriculture, which is overlooking, beef and that production, OSHA, Environmental Protection Agency, those all have regulatory authority. So let's go back to that chart I presented earlier and just focus on this column over here on the right. Conducting surveillance, yes, it's mandatory, but not usually enforced. Assisting physicians, that's voluntary. Interviewing cases requires cooperation. Nobody's going to tell you anything if they, by force. Investigating the circumstances and processes, it requires cooperation for the best results, but that can be mandatory. Identifying exposed persons, well, that requires cooperation. Who's going to tell you their sexual contacts unless they, have some incentive and some sense of trust. Organizing data and calculating attack rates, well, official health department duties, that's what they are. Usually does not require IRB as long as it's within some sort of framework that is called public health practice, which is different from research. Recommending or supplying prophylactic antibiotics, sometimes we make that mandatory. You can't get back into school until you've had another mumps vaccine or something like that. Isolating people who are contagious, that's usually mandatory and enforced. Quarantine, usually mandatory, requires some cooperation. As you'll see later, there can be a lot of people quarantined and it's not easy to keep up with all of them. And stopping ongoing exposure is best if it's voluntary, but it could be mandatory. So we're almost always trying to persuade a person to make a choice that benefits the person as well as the public health. So like this, no one is making you do anything you don't want. I'm just saying we're all headed to Dodge City and we think you should come along. There's a few other contexts in which we practice. Obviously politics. The health department is led by an elected official. That could be the president, the governor, the county commissioner, the mayor. Sometimes decisions are made by political leaders who are ignorant or ignore public health principles and data, and this may pose a dilemma for public health epidemiologists. And fortunately, there are times when the chiefs demonstrate outstanding leadership in support of public health, and I'll provide you a few examples later. Media attention. Well, it's a fact of life. And usually creates a lot of fear. These are all, and this isn't just a hyphen, that's a negative, okay? Officials taking unnecessary or inappropriate actions and restrictions, officials diverting resources from other important public health problems, so you can take all your money that was in cigarette cessation campaigns and put it into Ebola preparation, and that's, who knows if that's the right decision. There can be a lot of distortion and misinterpretation of the investigation, and the media can be extremely time-consuming. On the other hand, it gets in the media and cases can read it and they might report themselves. So that's a plus. But you also get non-cases reporting themselves, the worried well. So that's a negative. And you do have an opportunity to educate the public, and you might get an increase in funding. So, as I say, it's sort of two-edged here. Well, for most outbreak investigations and disease control using standard techniques, kind of listed before, public health laws and regulations are adequate. They're understood, they're in the background, they're unchallenged. The wind is at your back. And regarding disasters and emergency, most existing laws, it's possible they're not adequate if they address only floods, earthquakes, tornadoes, but not bioterrorism in pandemics. So we took a fresh look at this in the late 1990s after there was some evidence that terrorism was a growing threat. There was the 1993 bombing of the World Trade Center, the 1998 bombing of the U.S. Embassy in Nairobi. There were anthrax hoaxes in the U.S. in the late 1990s, and a sense that it was simply a matter of time before the next pandemic of influenza. Here's an MMWR from February of 1999, bioterrorism alleging use of anthrax. CDC received reports, letters containing anthrax were sent to health clinics, and those that's a euphemism sort of for Planned Parenthood clinics in Indiana, Kentucky, and Tennessee, also in California. And all threats were hoaxes, but they all required the FBI and local law enforcement to investigate. Then we had this. This is kind of interesting. February of 2001, this is from Newsweek, danger, terror ahead. Osama bin Laden's network is growing, so is the danger to America. So that's, 7 months before 9/11. Pandemic, flu, and bioterrorism are different. Why? The problem is big. It's not business as usual. It's a crisis. Okay, so you can't put them in the same ballpark. Bioterrorism is the intentional use of microorganisms or toxins of biologic origin to cause death or disease among humans or animals. What is a bioterrorist event? It's not only an epidemic, it's also an emergency, a crime, and a matter of national security. And what that does is it brings public health is not alone, it's not at the forefront. There's also emergency management, medical care providers, law enforcement. They're all going to respond simultaneously, and there's extraordinary coordination and communication challenges. What's the difference between bioterrorism and chemical terrorism or a 9/11 event? It's the incubation period. It can be a couple days to a couple of weeks. And unlike chemical terrorism or the 9/11 outbreaks, there's no single location that you can send all your first responders to. Ill persons present for medical care in widely dispersed locations days after the terrorists release the toxins or germs. As far as pandemic influenza, there's the definition. And it's large, deadly, and disruptive. It may affect unusual age groups. It can be at all locations. So if you're running low on some antiviral here in Denver, you can't go to Salt Lake City to get some because they know it's going to hit them sooner or later, and they don't want to give up their stockpiles. And it may occur at an unusual time of year. So here's the pandemic waves in 1918, 1919, and you can see we had one here in the summertime, another one here in the late fall, and another one here in February, March. And here's the death rate on the vertical axis and age group on the horizontal axis, and the normal sort of curve is U-shaped. That's the dotted line. But in 1918, it's also struck a lot of people in young adulthood. So bioterrorism in pandemic influenza may create very similar problems. So that's why they sort of group together. There's an extraordinary morbidity and mortality, greater than normal demand for health care. There may be a shortage of medical items. There's social disruption and high costs. There are different beasts. There's high visibility and media attention. There can be very frightening. Unusual control measures may be necessary. Multiple state and federal agencies may become involved. politicians may become involved. So within that, the rest of my talk is about, given these things, how do we make sure we have the legal structure in place to address these kind of problems? Well, let's look at a few outbreaks to see what we can learn. Here's the 1924 epidemic in Los Angeles. This guy is not from 1924, he's from 1630. Plague doctor. I got this photograph out of a book called Galileo's Daughter, but it was had a number of pages about an outbreak in 1630, and they weren't too encouraging. But in the interest of time, I've left that out of this talk. Anyway, this article was published in Lisa. I'll get back to you in a second on this. This is the last instance of person-to-person transmission of pneumonic plague in the U.S. The pneumonic form of Yersinia pestis is the type that would occur in a bioterrorist event. People would inhale the bacteria, become sick, and cough infectious droplets onto others. And if you need a copy of this article, go to Sarah Underwood. So here's how it unfolded. On October 29th, 1924, a physician requested an ambulance from the Los Angeles County General Hospital. There were 2 Mexican patients critically ill. The following day, 13 other cases occurred. They were admitted. They all had severe pneumonia. A couple of days later, the Macy Street area of LA, which included, was about 8 city blocks and housed 2,500 Mexicans, that's their language in the article, was placed in quarantine by the city health department. And I call that home or decentralized quarantine. The Board of Charities provided 7-day rations for each household, and they sent a Spanish-speaking priest and a social worker to the area to reassure and calm the residents. Public health nurses were also sent to make a house-to-house inspection. So that's what you have to do if you're quarantining people at home. They need food, they need their medicines, etc. Arrangements were made with the county general hospital to admit all persons who lived at addresses where there had been a case, and 114 people were put in the hospital. And this is what I'm calling as hospital or centralized quarantine. None of those became ill with plague, but if they had, then all of a sudden you've got a problem there at the hospital. That's part of the problem of centralized quarantine. It's easier to care for them, but it's a problem if you're mixing these people who could become ill. Then they formed a committee. They had an advisory committee. That's a great bureaucratic idea. Let's have a committee. Anyway, they got experts, though. That's the key thing. They got the state health department, the U.S. Public Health Service, the city and county health departments, and the county general hospital on this expert committee. They increased reporting, requiring everybody to report any suspect illness, and the medical society assembled and they provided education about pneumonic plague. And but who knows if that was the last case. This was published, and Lisa Miller was part of this, May 1st, 2015, about possible human-to-human transmission of plague in Colorado. Let me turn now to smallpox. There's 2 things I'm going to cover here. The 47 outbreak in New York City and the global eradication, 1966 to 77. The infectious agent is variola. Sometimes it's variola major, sometimes minor, depending upon the severity. The key epidemiologic parameters here is that you can give vaccine up to 4 days post-exposure and prevent disease. The incubation period is reasonably long, 10 to 14 days. The only reservoir is humans, and you don't really have asymptomatic transmitters. It starts when the rash begins. So it was a terrible disease. Look at these terrible pictures. Here's somebody in Nigeria with smallpox lesions. Here's somebody in another person in Nigeria, and well, it had been around for a long time. Here's Edward Jenner. He's the guy who sort of figured out that the reason the milkmaids weren't getting smallpox was because they were getting vaccinia virus, and there was some crossover between vaccinia virus and variola, and that if you vaccinated somebody with vaccinia virus, you could protect them against variola. Prior to that, people had been taking pus from a lesion of variola and nicking the skin, and a lot of those people got smallpox, so they didn't get protection. He published this paper in 1801, and says, one part of it says, it now becomes too manifest to admit of controversy that the annihilation of the smallpox, the most dreadful scourge of the human species, must be the final result of this practice. And it took 176 years, but then it did happen. So in 1947, there had not been any cases in New York City for 8 years, and there was an outbreak. And Israel Weinstein was the health commissioner, and he wrote this article, which amazingly was published about 6 months later in the American Journal of Public Health, and describing the outbreak. And the first case was misdiagnosed. And that was because the person said they had a scar on their arm, so they thought, well, they're immune, but that immunity lapses. Here's the New York Times. First mention of this outbreak was on page 21. So you got smallpox in city, inoculation urged, and vaccination was recommended. Every New Yorker who had not been vaccinated since early childhood. Can you imagine that? Page 21, right next to 50 saved parking fines by spreader of goodwill. That would not happen today. So this sort of, let's see, that was April 5th. So when we go forward to April 9th, here's the commissioner. He's vaccinating I think 2 of the nurses are employees. Here's one of their vaccine clinics. Look at them all lined up. And they renewed that plea for everybody to get vaccinated. And they had already distributed by April 9th 100,000 doses. And the department has another 500,000, but they need more. Now, I got vaccinated like in 2003 after the Iraq invasion, and took a really long time to get vaccinated because of the consent forms. You had to watch a video, you had to sign several consent forms. There was none of this mass vaccine. But they vaccinated 500,000 people in one day in New York. And they had already, by this time, April 18th, had 2 million vaccinated. They used police stations, 85 police stations as of this article. One day, okay? And so I put wow there because that's an amazing display, especially when you compare it to some recent outbreaks. Here's meningococcal meningitis, and they did 30,000 people in 3 days in 1995. Or in Florida, they did 13,000 people in 3 days. And in New York City, just giving out antibiotic prophylaxis for anthrax, they did 7,000 people in 3 days. So 500,000 in one day is pretty darn amazing. Well, this guy, Bertrand Ruchet, is one of my favorite authors. He does medical detective stories for the New Yorker. He's passed away, but he wrote this particular outbreak up, and I recommend this to you. And Sarah Underwood has a copy of this that you can read if you wish. It's just good detective reading, sort of. And I put up a few slides to sort of show how the health department worked behind the scenes and exercised their legal authority. So Dr. Greenberg, who was on the communicable disease staff, was trying to get the names of the employees, the hotel's employees where this index patient had stayed, and the other permanent residents there. And they encountered rigid opposition. But it wasn't too prolonged because Dr. Greenberg went to the telephone and said, well, if you don't tell us, we're going to give out the name of the hotel. Okay? And we'll just say, everybody who stayed at this hotel, you could have been exposed. And his, as it says, his words introduced a cordiality of such intensity that the manager himself trotted out the records and asked to be first to bear his arm. Then they had a problem. They were running low on resources. So Dr. Weinstein and one of his colleagues went to the mayor of New York City, and they told the mayor what was going on. They hadn't really wanted to tell the mayor too much to spare him of all the details, but they said they were uneasy, and they asked the mayor for $500,000. The mayor agreed to wheedle out of the Board of Estimate would be that the money would be spent for vaccine. And pretty soon, the mayor led the group down to City Hall at 5 o'clock. He met in his office with the commissioners and instructed them to see to it that no city employee delayed an instance in getting vaccinated. And then he called in the press and got himself vaccinated. And he pointed out this was his 5th vaccination in 6 years. So once again, sometimes the politicians can be a big help. At the end of that article, he advocated for a primary strategy of mass vaccination. They had 179 city installations. They were working from 9 a.m. to 10 p.m. 7 days a week. They used They used all those police stations. So they really increased the delivery, but they had to really recruit all sorts of community resources to do it. In his last sentence, he says, just as soon as a case of smallpox is suspected in a community, every effort must be made to have everyone vaccinated without delay. I can't remember the total number of cases, but it was under 20 in that outbreak. So a lot of people vaccinated, 20 cases. And in 2011, Bill Foege, who was once the CDC director, he's still alive, and has also worked on the CDC smallpox eradication campaign, said the strategy of mass vaccination, which was what Dr. Weinstein advocated, is founded on the assumption that it's not possible to know where a virus is. Therefore, one must assume that it could be any place, and the appropriate response is to protect everyone to achieve herd immunity. And that logic works with most infectious diseases, but not with smallpox. So here's that logic. Okay, here's a 10 by 10 table. The white squares are unvaccinated people and the gray are vaccinated people. So we have 80% coverage in this particular drawing. And so the herd immunity is coming because if this person is exposed, they are surrounded by vaccinated people. Okay, but that's not actually how it works, because this is really more what it's like. These people, unvaccinated people, frequently are clustered because they share the same personal beliefs or religious beliefs, or maybe they can't get certain services. So that's the problem with herd immunity. So the Eradication Campaign, here are 3 of the great leaders of public health who worked on that. Bill Foege, right there at the top. Don Millar died a couple years ago, but worked throughout CDC for many years, and D.A. Henderson, who was at the World Health Organization, and actually when I got my MPH, he was the dean of Hopkins and signed my degree, thank goodness. Anyway, so this campaign started in 66 to 71, and it was sort of, the strategy was surveillance and containment. Rapidly find all the cases of disease, identify and vaccinate close susceptible contacts, and build successive rings of immune persons around the reported case. So it's kind of like that, okay? This case gets reported, and because of the incubation period and because of the ability to give vaccine within 4 days, if you can get rapid reporting, you might be able to surround this person, vaccinate all these people, and prevent it spreading further. Because even these so-called immune people, it's not 100%, and some of them may become cases. So here's how they got rapid reporting. They made up these cards of these this baby or babies with smallpox. And in this particular picture here, left is Somalia, right is India. You can see this guy or this guy is holding up that card. Okay, he's doing it there, and they're showing these little children, here's what a case of smallpox is. Has anybody seen anybody like this? So that's, they got the surveillance down, right to the front lines of transmission. But it's very labor intensive. In Bangladesh, 71 and 75, when the campaign started, in 1971, there were 75 million people. They had 12 Bangladeshis and 3 international epidemiologists. And by the time they got to the last case, a 3-year-old girl, they had 100 Bangladeshi epidemiologists, 12,000 local recruits, 13,000 village recruits, 75 international health workers. So that you have to mount a big force to do surveillance and containment. And this is the last case. Ali Malin, Cook in Somalia, 1977. Last case of naturally occurring smallpox. There was a case of laboratory smallpox in 1979. And what were the lessons learned? The fact of smallpox was so ingrained in human experience that we had our work cut out for us to convince people that eradication was not a wishful fantasy. Our task was not to vaccinate everyone in a certain range, but rather identify and protect the nearest susceptible people before the virus could reach them. And from the very first days of the eradication program in Africa, it was obvious that fighting smallpox was not just a medical or scientific endeavor, but was very much a matter of management of all those people. But we did triumph. May 1980, the World Health Organization decreed that smallpox was eradicated, and it's the only disease so far, though we're getting close with some others. I thought I'd briefly turn to influenza. So these are new guidelines. This is April 21st, 2017 on community mitigation, and it's a recommendation report from CDC. So you'll have to look that one up online. But I only put this little chart in here because it shows, here's the horizontal axis, scaled measure of clinical severity, the vertical axis, scaled measure of transmissibility. So 1918, wow, really is an outlier there. And these two, 57 and 68, were pretty severe. The 2009 pandemic, which caused enough problems on its own, primarily because we can't make vaccine very fast. It took 6 months at least to get vaccine made after identification of that this was a different strain. It's not really in the same ballpark, but that kind of stressed the system quite a bit. And then we have these more recent ones that are lower severity. So the mitigation measures against influenza were actually the same ones that are in this recommendation and report from 10 days ago. Respiratory hygiene, cover coughs, use masks, disinfectants. Remember how all of a sudden Purell appeared in all these elevators? I mean, there was Purell everywhere in 2009, but really wasn't a lot of it before that, at least in my memory. Social distancing, forbidding public gatherings, temporary medical housing facilities, and dealing with the dead, mass graves. Those were all measures taken. So quickly, you've probably seen some of these pictures before of soldiers wearing masks, and of course these guys are that age group that had the high mortality. And of course they're sleeping in barracks and are close together, so that's part of the reason. And disinfecting the environment, I modified this slide because I used to have it with SARS in Hong Kong in 2003 right next to it, and they were doing the exact same thing. Social distancing. This was a violation. They weren't supposed to have this church gathering, but at least it was outdoors and they wore masks. And they had all these temporary hospitals. Well, just so you know, temporary hospitals is not that easy a concept because, people start showing up at different hospitals around Denver, and we now all of a sudden got to say, no, you can't go there. We got to go to this abandoned Kmart building that has become our new hospital, and these mass graves. And this mass graves is certainly an issue, and I'll show you something in a few minutes about that. So here are those new guidelines. I've only given it a cursory review. But one thing that those guidelines don't address, and became a realization in 2009, was there's a limited number of ventilators, and currently they're going on a first-come, first-served basis. But that may not be what you want. So we have not addressed who should receive life support during a public health emergency. And how do we do that? Because the individual doctor cannot really tell the family. They're in an extremely awkward and difficult position. So you're going to need some kind of structure to say, relieve them of the responsibility, relieve the hospital of its responsibility, and say we're following some sort of state guidelines or regional guidelines. Well, here is another big epidemic. It's still going on, not as bad, but in the 1980s, we had 3 epidemics, AIDS and HIV, and then we had a fraids. But public health did deliver a message on its own terms, as opposed to the media's terms. And the Surgeon General, Everett Koop, sent a 4-page pamphlet to every household in the United States. That's the only time that's ever been done. And there it is. There's Everett Koop, who was kind of unusual because he was thought to be a right-wing, very conservative pediatric neurosurgeon, and he turned out to be a wise person who wanted to fight disease. No, I mean, he really took his role as a leader seriously, and he did lead, and this is part of it. So he sent this. This is page 1. Page 2, we have Tony Fauci. This is 87 or 89? There, he's still around today leading us. And what does someone with AIDS look like? Should you get an AIDS test? You know, helping a person with AIDS. That's Jim Mason. He was the director of the CDC at the time. And what do you really know about AIDS? Are you at risk? AIDS and sex. Why no one has gotten AIDS from mosquitoes? Okay, there's a lot of fear out there. So this was, I put this as an example of we need to do our own education to help stop epidemics. Let me move to anthrax. Here's Newsweek again. I don't have a subscription to Newsweek. I don't know why I got all these Newsweeks. But how scared should you be? Well, that cover looks to me pretty scary. I think the answer is obvious there. And it was scary. This was sort of typical of the times, this cartoon. Attention, we interrupt this emergency breaking news bulletin with an even scarier emergency breaking news bulletin. I mean, it really was. But the number of cases was only small. There was a total of 22. 5 previously healthy persons died. The disease was spread through the mail. Everybody receives mail. Epidemiologists had no experience with anthrax transmitted in this manner. Dr. Miller, I just left the health department. She had to deal with it up in Fort Collins, and I'm sure she could tell her own story. The public health system was overwhelmed. Many persons observed powders that they wanted tested for anthrax, and many persons had questions about how to protect themselves. These were 2 letters. This one went to New York to Tom Brokaw, who was the lead evening news commentator, reporter, and Tom Daschle, who was the Senate Majority Leader at the time. Both of those had anthrax spores in them. I happened to be in Washington going to a bioterrorism conference, and I kept the paper because here's Secretary Tommy Thompson saying there was heightened awareness, October 3rd, 2001. So this is, 3 weeks after 9/11. And what does he say? He says the September 11th attacks, he's put the Office Emergency Preparedness on duty 24 hours a day. The same goes for the CDC. Every day for the past 21, he's met with his bioterrorism team, and we just have a real heightened awareness, ready to move if, in fact, anything could come about. And on October 5th, here was the headline of the New York Times: we're all getting ready to go invade Afghanistan. On October 5th, later, further back in the paper, though, there was this article: Florida man is hospitalized with pulmonary anthrax. The next day, he died. And all of a sudden, you see the FBI is involved. Because we can handle a cutaneous anthrax, but pulmonary is a different matter. Where is that coming from? But one case, who knows? Assurances that an illness does not point to terrorists. Then all of a sudden, terrorism is not yet ruled out. And on October 8th, the front page is about Afghanistan, but further back, there's a second case. Okay? And then on the 11th, all of a sudden, there's a third case, and it's now on the front page. And on the 13th, it's now found on the top of the front page in an NBC News aid. And then by the 14th, it's taking up more columns. What is that? 4 columns. So it's getting to be a much bigger story. And by the 24th, we got these guys looking like that plague doctor from 1630 walking around while President Bush is trying to reassure the public. There's a contradiction going on there. That's not reassuring. And then the 31st, hospital workers' illness suggests widening threat. Anthrax mystery. Anytime they use the word mystery, it's a problem. And this hospital worker was exposed to anthrax, and how, that was never determined, at least to my knowledge. Then we had confusion, anxiety, and they closed a hospital in New York over threat of contamination. Threw a lot of antibiotics at the fire. And here we are, December, and there's this continuing relentless flurry of anthrax false alarms. And they could have substituted Colorado or any state there in terms of how it was taking up resources. And here's the actual epidemic curve, and I put this up. These are all these cases. But the reason I put this here is because Secretary Tommy Thompson had that article on October 3rd of heightened awareness, and here's all these cases that had already occurred. And he was unaware, because these were cutaneous cases, and they were being misdiagnosed as spider bites and things like that. So you get the right disease or the wrong disease, you can, despite having good surveillance, you may miss the whole problem, at least as it's starting. Here's the Denver Post, November 9th. 32,000 people have given antibiotics. I found this interesting, 5,000 who really needed them. Okay, there was a run on ciprofloxacin, and we ran out. SARS, it's caused by coronavirus. There were cases in 26 countries, but we haven't seen it since April 2004. In Beijing, there were 2,500 cases, 192 deaths. Article looked at the control measures they needed in this sort of 2-month period: 11 million surgical masks, 758,000 gowns, 2.9 million pairs of latex gloves, 1 million thermometers, 76 new ambulances, 759 ventilators. They mobilized 3,500 people, 123 fever clinics were set up, 2,100 close contacts were quarantined, 30,000 other people were quarantined. So now you can see quarantining is a big burden for the health department. 3,500 public places were closed, 2,600 universities and public schools closed, 8 million copies of educational materials distributed, 13.8 million people screened for fever. And the government sealed off Beijing University, several thousand people. Here they are behind essentially bars, 4,000 people in isolation. The president of China got interested. Everybody's smiling, but actually some people thought the response was too heavy-handed. They hurried to build a hospital in less than a week. Okay, 4,000 construction workers. So that wasn't listed on my previous slides. Working around the clock for 4 days to build a new SARS hospital. It's scheduled to be finished tonight. Are you ready? Here's what it looks like. That's it. That's the only picture I've been able to get of that SARS hospital. But it looks to me like there's individual rooms rather than a common ventilation system. After completion, 40% of their patients were treated there, and it had 6,700 beds capacity. In Toronto, they had 225 cases. It cost them $1.13 billion. There were 23,000 contacts requiring quarantine. 13,000 complied. That means 10,000 didn't. They had 316,000 calls to the public health hotline in this, 3 month period. The maximum number of calls in one day, 41,000. That's unbelievable. Number of calls handled by a staff person in one day ranged from 214 to 1,471. So that, those things really illustrate the magnitude of what you have to do to gear up. Thousands of cases of Ebola in Liberia, Guinea, and Sierra Leone. Healthcare workers participated in the response by volunteering in West Africa. And most of this little section is about the U.S., but I did want to show you, here's an anguished family member watching a loved one being taken away. Once again, these guys in the plague suits from 1630. And they had to change their burial practices. So there's a lot of social custom involved in that, a lot of religious beliefs, and it's very difficult. But transmission was occurring because of washing the bodies, the corpses. Anyway, we had some leaders in our country not giving a very positive image, such as Andrew Cuomo and Chris Christie, and they put this nurse who returned from volunteering in some very drastic quarantine unit. She was completely asymptomatic. But Dallas had a nurse who was contracted or caught Ebola from a patient who was not, I guess, identified as having Ebola. He was in more of a prodromal stage. And so Dallas had to deal with this case on October 13th. And here's a county commissioner. And I like this photograph because this guy is not wearing a plague suit. And he's going into the apartment where the index case, had been living. So he's sort of showing that, look, it isn't going to just spread through the air. And in New York City, we had a nice panel, including the mayor, Bill de Blasio, and we had Rima Kabaz from CDC right here, and this Mary Bassett is the health commissioner for New York City, and so I like that photograph because it's a teamwork issue, and I highlighted on here that Mayor de Blasio rode the subway to demonstrate that virus could not be spread through casual contact. And then we had President Obama hugging the nurse from Dallas, once again showing that she was healthy and not contagious, and that was a good image. So leaders can do a lot, especially when you've got this kind of problem. Bellevue employees face a virus at work, the stigma of it everywhere. Some nurses are said to be shunned by their own colleagues in the hospital elevators. This, by the way, is 3 years ago. And here's the National Institute of Health, which took a couple of these patients, and they had all sorts of problems with their own staff, and they should have been well trained and well educated, but there was a lot of news media around that spooked everybody. Most clinical staff were supportive, however, very few were openly contentious about the risk. They had problems with landfill owners refusing to accept ashes from autoclave waste incinerators. The volume of calls to their unit required the full-time attention of a staff member, and one staff member who volunteered whose child was enrolled in a home daycare was asked to find an alternative center. So this came from an article that, once again, if you're interested, contact Sarah Underwood and she'll give you a PDF of it. So here's what I take from this. In plague in LA in 1924, we had this committee structure, mass quarantine, centralized and dehumanized. In New York City, smallpox, mass vaccination was advocated. It required surge capacity of a huge magnitude. In the eradication, we had to have a surge capacity of a different sort, surveillance and management. In pandemic influenza, we needed surge capacity of medical care delivery and rationing, potentially. Anthrax, coordination of emergency management and law enforcement. There was a big burden of the worried well. Same thing with SARS in Beijing and Toronto, mass quarantine, infection control issues, worried well, creation of a special hospital. With AIDS and HIV in the U.S., fear. We needed leadership, confidentiality. There was a lot of stigma. Ebola, we need leadership, training and infection control, designated facilities, and early suspicion of the disease. And then I just added, who knows what social media will do to all that I've presented already. So with that, trying to take lessons from those outbreaks, let me kind of review a few legal strategies. In response to one of these outbreaks, we don't know whether the agent's contagious or not. Anthrax is not contagious person to person. How many, we don't know how many people have been exposed, how many are ill, how exposure occurred. Has anybody here been to the back of a post office and seen behind the scenes? Maybe Lisa, but it's unknown to me how it works back there, so how would I know, how the spores are getting aerosolized or inhaled or whatever? Whether antibiotics or vaccines are effective, and how panicked is the public. So these factors are not predictable in advance. So we need a flexible approach. It needs to be applicable to any disease, and it has to be designed to care for infected persons as well as unexposed and frightened persons. Well, we can turn to the federal government. It'll provide medical, epidemiologic, and laboratory resources. It'll coordinate disease investigations, and it'll screen portals of entry into the country. But states still need adequate legal authority to do their job, what's necessary. And that needs to include sharing of information with other state and federal agencies. By that I mean some of these cases we can't protect confidentiality because the FBI wants to know who the predators are, and they need to investigate the cases if they're alive and can talk. Epidemiologists aren't going to be in charge. It's going to be the mayor, the governor, or the president. And we're going to change our structure from our current, whatever bureaucratic structure it is, to some sort of incident command structure, similar to a field military organization. So you may end up reporting to a new boss or reassigned to a different job. We need to make sure the governor has the best possible technical advice. So in Colorado, prior to 2001, the governor's advice was coming from the secretary or executive director of agriculture, from the attorney general. There was nobody from health. It wasn't that he couldn't ask for that, but they were not listed in the statute as one of the advisors in a disaster situation. You need to assure that there are sufficient numbers of workers and sufficient financial resources, that there's good communication with medical providers and the public, and you have to allow for the exchange of confidential information between public health, law enforcement, and emergency management. So to get sufficient numbers, people have to show up for work. That's step one, all right? So, but if they do, then they may be reassigned from doing their usual tasks. They need training, and they're going to need personal protection, not only for themselves, but for their families. And, it's kind of like that nurse or worker at the NIH who child was excluded from daycare. I mean, even though there's no transmission going on in the building of the health department, people aren't going to be wanting to leave their home unless they're going to be okay and their family's okay. So you might need an expert committee that could recommend to the governor which persons should receive medicines and vaccines first, or ventilators, ordering that suspect patients be sent to a temporary facility, that there might be large-scale quarantine, which is a legal issue, because if you said everybody at the Pepsi Center, we don't have the names of everybody at the Pepsi Center on that particular night when there was an aerosol. So it's legally tough to say if you were there, you have to stay home for 14 days or whatever. Whether to destroy or decontaminate property that may be a threat, how to dispose of corpses. There is some legal authority for that, but in Colorado by the health department, but I think it's not going to work. I think the governor would have to be the one to say we can't bury people in the usual way. And there needs to be mental health support to affected persons. So one thing you can do with laws is remove barriers. So you might need to provide legal immunity to that expert committee. If they're going to make life or death decisions, they might say, I'm not going to serve unless you provide me with legal immunity. And hospitals might give up their storage of certain medications or ventilators, but they're going to need legal immunity if they're going to do that, because if you're Kaiser and you just gave up your antivirals for the good of the public, and they might get a hard time from a Kaiser patient who said, wait a minute, here's the tough times, and all of a sudden you gave it away. I'm suing you. You might have to compensate doctors. So if you get an ophthalmologist who's giving vaccines and then they get sick, what's going to happen? They need to be included as workers' comp. You might have to get enough people, we might have to let unlicensed MDs and RNs work under supervision, or non-MDs and non-pharmacists dispense medicines. Adolescents might need permission to obtain treatment without parental consent. And there might need to be some sort of compensation to persons who are quarantined and cannot go to work. And that one's a real tough one to figure out, because in Toronto, that's part of the reason there were 10,000 people who didn't obey quarantine orders. So the old public laws that give the health department broad power are not adequate for these extraordinary situations. New bills may need to be drafted and submitted in advance of a crisis. So let me summarize by just saying public health practice operates within this legal and political context. It's not just collecting data and analyzing it. Public health practice, it's constantly changing. Laws are one expression of public policy. The legal authority must keep pace and update as necessary. We have an interest in making sure the laws work for the problems we have to solve. We are fighting the disease, not the person. And with effective leadership, fear will be lessened and better decisions will be made. And my mouth is dry, and that's it. Thank you very much. If somebody wants to make a comment or ask a question, be happy to entertain. But I can't see until I get these on. There we go. Yeah. Could you elaborate on what you mean by protections, legal protections?
I'm thinking more about like surveillance for these other things. So it seems like a lot of the laws are really written specifically for surveillance, monitoring of infectious agents with communicable potential. But in public health departments now, we're focusing a lot more on non-communicable patterns in the public trend.
So really surveillance, is that okay to boil it down to that. So Colorado's had actually an environmental and chronic disease surveillance law. I didn't discuss it today because it sort of didn't blend in with all this smallpox and anthrax stuff. But you're correct that we do need to be thinking about that. And so we have reporting of all sorts of non-infectious diseases in the state that is mandatory, that's under that same umbrella. Earlier, I don't think I can quickly put my go to that slide, but the 1991 authorization of the board to require reporting didn't restrict itself to communicable diseases. It involved all types of diseases, including suicides, or we already had death certificates, but cancer. We've tried all sorts of lead poisoning. There's fetal alcohol syndrome, now that I see Lisa sitting there. A lot of non-infectious diseases can be reported. That doesn't mean she's prompting me throughout the lecture, or at least the thought of her is prompting me throughout the lecture. So there is a lot of that, but there's another aspect to what you're saying, which is reporting behaviors. So reporting behaviors is a different matter, and it's not as clear cut to me. So that behavior might be a risk factor, but it's not easy to get that kind of reporting, even if you have the legal authority. Yes.
I just have a question. So I'm actually a public health law and a scholar and a historian.
Good.
So, no, this is great. I just have a question. So you were talking about how one of the imperatives was to treat the disease and not the person. But we know from the history of public health, especially in NCD management, that we failed at that generally more often than we've succeeded. Right? So I guess what I was wondering is what strategies do you see in your experience that would help us do a better job of that? Because historically we have done a pretty poor job of that in this country.
Well, the image that comes to mind is somebody very angry and hostile. And so we have to have leadership in a calm leadership explaining what it is we're trying to accomplish here to that person over the telephone or that person at a meeting or through the newspaper. So that's the best way in my experience, was to try to present, and sometimes you have to say exactly that. Hey, we're not trying to hurt this person. We're trying to help this person, but we also have to protect these other people. And frequently, when doctors don't report, we have to explain to them what is the purpose, what the health department is trying to accomplish, and that we're actually on the same team. So that's all that's why you need a good spokesperson, and sometimes you don't always succeed at that. Yeah.
You had mentioned earlier about the example of the epidemiologist in Michigan who was sued, or who was.
She pled guilty.
I know that Christine Whitman, the administrator of EPA, was sued after 9/11 because she issued a statement saying that it was safe to go back into the area 2 weeks afterwards. And, we know now that there were many people who were still affected, and the air was not necessarily safe. And I think that she was allowed to be sued. I don't think that she was granted immunity, but I don't remember the details.
Do you know anything about that?
A little bit. So sovereign immunity is a very broad protection for state entities and state officials, but it's not impenetrable. Right, so if you're grossly negligent in the execution of your official professional duties, then you can still the protection from sovereign immunity can be penetrated. So I don't know the details of it, but my guess is that's what they allege. They allege facts that would give rise to an allegation of gross negligence, and then as an individual, even if you're acting in the fulfillment of your official duties, you can still be held personally liable. That's my guess.
That would be, and it wasn't clear to me. From that all I have is that New York Times article, and it wasn't clear to me what Corrine Miller had done wrong. She didn't notify people there was Legionnaires, an outbreak, but that doesn't mean they weren't trying to stop it. or investigate it. So there isn't enough information there. But I've never noticed that a state health epidemiologist has ever been found guilty or pleaded guilty previously. We've had plenty of people who have quit their jobs because they disagreed with the governor or somebody or their executive director. There was a policy difference. That'll happen frequently, but this is a different matter. Yeah.
So I don't know if you've given yourself enough credit for creating the Governor's Expert Advisory Committee, which still exists. I don't know if people know that, but that committee still exists. And I think we struggle a little bit as we get more and more distant from the anthrax event about keeping up the motivation and the purpose of that advisory committee when really there hasn't been really a use of it. So I'm wondering what your thoughts are about how to keep that function alive and keep that motivation there. Just the day workings of that committee. They're ready to go when the governor might need them.
Well, thank you. First thing I'd say is I was genericizing this talk and trying not to be too specific to Colorado.
You did those things.
But it's been changed over time. But at a minimum, even if it's atrophied a fair amount, there's the structures in place so that it could be reconstructed pretty fast. It's got in this Colorado law, at least, here are the types of people who compose this expert committee. So I don't know how to keep it going, but at least in the crisis, we've got a structure in place that's better than just having the executive director of agriculture and the attorney general making decisions. So. And there's legal immunity for them, and so I think we would pull together and get something going. We may not have, the world's greatest experts on whatever that problem is right now, and as I say, there's still big problems that we haven't addressed, such as this. How do you keep people in quarantine if you have to quarantine thousands? And how do you have enough ventilators or allocate your ventilators? We have not addressed those issues. And, the governor's expert committee could say, let's deal with the ventilator issue ahead of time. And that would be good if they would address that. New Jersey has done it and New York has done it, but I'd like to see that. Yeah.
So there's currently a revision of the crisis standards of care being done by the health department, and it basically will report up to the governor's committee, the GERC. So they'll get a chance to review that and sign off on preparing for that. So that's a revision of the pandemic plan from 2007, 2008. So that stuff actually is being worked on. And
okay.
GERC is an integral part of reviewing that.
Well, there you go. That's good. And then these community mitigation guidelines that came out 10 days ago, you should may want to look and see how to apply them in Colorado. Well, thank you all very much for your attention. It's a long talk, but I do appreciate your hanging around till the